Lung ultrasound was my introduction to POCUS, and it blew me away with how powerful a tool it can be. In this video, we'll walk through how to perform a lung ultrasound exam. I'm Dr. Alex Estelle, and this is SonoCare. This video is an introduction to lung ultrasound. Much like with everything POCUS, understanding how is the first step, but mastery requires supervised practice as you build the image generation and interpretation skills. I hope you can use this video to help kickstart scanning with a local mentor as you build this skill set. The scanning protocol I use, and the one best supported by the evidence, is the Blue protocol. It was developed to help diagnose patients presenting with dyspnea with an accuracy of 90% for coming to the right diagnosis. It easily outperforms a chest x-ray, takes only a couple of minutes to perform, and exposes your patient to no ionizing radiation. The Blue protocol examines each lung at 3 points. I use a curvilinear probe set on the abdominal preset, though a phased array probe works as well. Many machines have a lung preset, which you can use, though I found the abdominal preset on most machines provides clearer images. Scanning is performed with the probe marker up towards the patient's head at all times. For the upper lung zones, you want to set your depth around 10 centimeters, and the lower lung zones typically require a depth of 15 centimeters. For obese patients, you will need to increase the depth to account for the additional distance to the pleura. Finding the right alignment with the pleura is critical to generating high-quality lung images. To be able to best visualize pleural sliding and generate lung artifacts, we need to have the probe perpendicular to the pleura. The pleura is often not in the same plane as the chest wall, so you will need to tilt the probe back and forth until you brighten the pleural line and generate distinct lung artifacts. This is where supervised practice is really important in learning how to optimize the images to avoid missing findings from not properly generating the artifacts. For the upper blue point, we place the probe 2 fingers below the clavicle in the mid-clavicular line, making sure the middle of our transducer is between the ribs. We can then tilt side to side until we find perpendicular to the pleural surface and generate lung artifacts. The lower blue point sits at the anterior axillary line 1.5 hand widths down from the clavicle. Again, we want to ensure our probe is in between the rib spaces as we tilt to find perpendicular to the pleura. The PLAPS point, the awkwardly named lowest lung zone, is described as the intersection of the posterior axillary line and a line connecting to the other 2 blue points. Pragmatically, as we're looking to find the base of the lung where it meets the diaphragm, we want to make sure we're as far back around the chest as we can be and that we see the diaphragm. It can be a bit tricky to find the diaphragm as it is obscured by a well-aerated lung. If I'm having trouble finding the diaphragm, I move the probe inferiorly until I find a solid organ and then drop the tail of the probe to look up at the lung. I then move up 1 or 2 rib spaces as required. What we're trying to avoid is either an image that's all solid organ with a hint of lung, or a lung view with no diaphragm or solid organ to confirm that we're truly at the base. Sometimes we have to compromise and accept a rib shadow in the middle of our field if the ideal window just isn't available to us. As we see in this clip, a rib shadow is right over top of where we'd like to see the diaphragm. But as we're seeing lung on the left side of the screen and solid organ on the right side of the screen, we know we're looking at the base of the lung. While the hardest to generate, the PLAPS point is the highest yield for finding lung pathology. Both consolidations and pleural effusions are more likely to be found posteriorly, so it's really important, particularly in supine patients, to get the probe as far around the chest as possible. Here's a good example of a patient I scanned who was ventilated and on quite a bit of oxygen. As you can see, the lower blue point's not all that remarkable, but the PLAPS point shows a fairly dense consolidation from pneumonia. There was significant shunting through the consolidation that explained the hypoxemia. Interestingly, the pneumonia did not show up on chest x-ray. As I said, lung ultrasound outperforms chest x-ray, making it a valuable tool in our toolbox. That's the basics of performing a lung ultrasound exam. Make sure you check out my videos on lung sliding, the 4 basic lung ultrasound artifact patterns, and how to differentiate pneumonia from atelectasis. It takes some practice to refine your images, but with a short learning curve, you can be using this skill in no time. If this is new to you, find a local expert or colleague who's comfortable with lung ultrasound to help guide you through the learning process. I hope you found this video helpful. Now get out there and scan.